Good morning, everyone. Good morning. Thank you for joining us for today's webinar titled Working Towards FASD Prevention Within Pregnant Population Facing Multiple Barriers to Health. For your information, all participants' microphones are muted today. If you have any questions, we ask that you please use the Q&A box that is located at the bottom center of your Zoom window taskbar. The chat box is also available if you have any comments or technical support questions during the presentation. As a reminder, this webinar is being recorded. The recording will be available on the Saskatchewan Prevention Institute website and will be emailed to you in the coming days. My name is Christy Inegbebo. I'm the FASD Prevention Program Coordinator with the Saskatchewan Prevention Institute. The Saskatchewan Prevention Institute provides services to all those living on Treaty Lands 2, 4, 5, 6, 8, and 10, the ancestral territories of the Nehiyawak, Nehidawak, Nehinawak, Anishinaabeg, Nakewe, Dakota, Lakota, Nakota, Dene, and the homeland of the Métis. We recognize that these lands are currently inhabited by Indigenous people from across Turtle Island, including many other First Nations and Inuit people, and acknowledge the importance of the treaties, the lasting impact of colonization, and continued inequities. We're dedicated to moving forward on a shared path of reconciliation and partnership. We are all treaty people, and we're grateful to live, work, and play on this land. Today's presenter, Heather Cameron, is a registered nurse with the perinatal specialty certificate who has been working with pregnant people in a variety of settings since 2005. Her experience includes program planning, public speaking, and spearheading community development events. As a registered nurse, Heather worked in several fields, including withdrawal management, labor and delivery, and maternity. Heather has a proven track record of being able to bring communities together with her experience organizing conferences, creating grassroots programs, and influences system change at local, regional, and provincial levels. Two projects that Heather is most proud of include a pair-based recovery support group for birth parents affected by substance use, Mothers for Recovery, and the Healthy Care Pregnancy Program that supports perinatal people who use substances. Heather may be most known for her perinatal substance use training that she created and has been presenting since 2007 throughout BC, Canada, and beyond. Her volunteer involvement on a variety of committees, including Foundry Kamloops, Make Children First, Perinatal Connections, Raise a Reader, and Sex Workers Assessing Treatment, SWAT, has influenced Heather's knowledge her knowledge base and ability to create impactful change within communities. Heather's experience, passion, and credentials all contribute to her drive to guide BCA POP as Executive Director. So welcome, Heather.
Thank you so much, Christy. What a great introduction, and good morning to everyone. I really appreciate your land acknowledgement, the lands you're calling in today from, Christy, and I will also acknowledge that I'm calling in from the traditional Secwepemc territory, colonially known as Kamloops. Really thrilled to be here. Not used to people reading my whole bio, and that is always an uncomfortable moment, but thank you so much for the nice introduction. I'm really thrilled to be here. If you have ever heard me speak before, I see a couple names for sure that I recognize from here in British Columbia as well as in Ontario. You know that this is my absolute favorite thing in the world to do, and there is nowhere else I would rather be. So I'm just going to go ahead and share my screen. Today we have 2 hours together. We're going to cover quite a bit of content as well as some storytelling, which is always such an effective way I find for us to do learning together and for sharing experiences. Perfect. So this is definitely a combination of, we're going to review a little bit of content some of you may have heard before, but definitely with a purpose. And then there's definitely new content created here specifically for this group, specifically for this event. So about 80% of the content was created for us just for today. So I'm going to do our BCA Pop virtual land acknowledgement as well. I would like to begin by acknowledging the Indigenous peoples of all the lands we are on today. While we meet today on a virtual platform, I'd like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we are and can each in our own way try to move forward in a spirit of reconciliation and collaboration. Please join me in a moment of reflection. Thank you so much. All right, I always like to talk about content awareness. So alcohol use disorder, FASD, perinatal substance use, all these really gray areas, all of us bring to the table today our own history, our own stories, our own professional experiences, our own personal experiences. And I know this, I usually get to know this best, of course, when I'm in person doing training and hearing people's other stories, but it really impacts how we can receive content. So I will not be offended at any time, and please care for yourself. You only know your own story, your own experiences, but please feel free to take a break at any time if anything becomes overwhelming. I think the practice of self-care really comes into opportunities where we're accessing training where the facilitator, of course, does not know our own personal story. So I really encourage you to ensure that you care for yourself during this 2 hours this morning. This is probably my favorite slide. So take what fits and leave the rest behind. And this probably took me many years to realize that this was okay. So when I am presenting to you and I am sharing evidence-based information and evidence-informed content, that's fantastic. But of course, in the world of alcohol use disorder, perinatal substance use, and when I say perinatal substance use, I'm including alcohol as a substance. There is a lot of gray area. There isn't a ton of black and white, especially when it comes to opinions, approaches, strategies, or stories. So please take what fits for you and just leave the rest behind, and that's absolutely okay. I am always open. At the end, I'll leave my contact information. I'm always open to discussing things further because, of course, that is how I learn and improve as well. And you're welcome to put questions into the Q&A or the chat. And I know Christy is going to moderate that and she can interrupt me anytime and we can talk a little bit further. But it's absolutely okay to disagree with some of the things I say and just to take what fits for you in your practice in your life at this time. And it's important we're both okay with that. So today's 2 hours together are learning outcomes for everyone who's joining us, as well as the people who are going to be able to view the recording, is to be able to identify evidence-based resources to share with your participants, clients, or patients, and also evidence-based resources to find more information for yourself if you're just starting this journey on supporting pregnant people who are using alcohol or other substances. Also to be able to identify basic strategies to support FASD prevention. If you've heard me speak before, you know I'm going to come at this with a fluffy, smiley, grilled cheese sandwich approach, and that's what I'm going to share with you. We will get into that further, but it might be a little bit different than what you've heard before, or it might be similar. Or best case scenario, it is confirmation that you're already doing the things that have been proven to be best practice support, and that really is just confirmation for your practice that you're already doing and to do more of that. And then the last one is to identify tools to start conversations about preventing FASD. I have found over the last 20 years the most effective teaching I do is to support perinatal professionals and helping peers to talk to their participants or patients or clients, and how to start that conversation, and how do we start connecting with people who may be living a very different lifestyle than ourselves, or are living a lifestyle that we have experienced ourselves as well. It can really vary. So I'm really looking forward to jumping into that because it's probably my favorite teaching to do. Before I tell you a little bit more of the fluffy stuff about me, we're going to do comfort scale together. So comfort scale, we have 3 comfort scales today. They're all about alcohol use disorder. I either encourage you to write it down on a piece of paper privately or throw it into the chat. I love to look at it when people answer because it kind of directs where we're going. But let's try this first one. So the first one is, the statement is, I'm comfortable sharing the basic risks of alcohol use during pregnancy with my patients, clients, or participants. 1, being very uncomfortable, and 5, being very comfortable. There we go. Thank you for throwing it into the chat. I love to see these things. Thank you. So I see some really honest answers here. Some people are giving 5, some people are giving 2s, and I love both of those, right? I know that usually people who come to, trainings around FASD prevention or alcohol use disorder or substance use disorder. Often there's a population who's already really, really fantastic with that population. It's their specialty. I know we have some people in this group, and then we're going to have other people who are just dipping their toe in the waters. So thank you for participating. That's great. Thank you so much. So that's just about basic information sharing, and we're going to cover that today. Our next comfort scale is, I am comfortable supporting pregnant people with harm reduction strategies that aim to reduce FASD. So harm reduction strategies specifically for the pregnant population or people who are about to get pregnant around alcohol, of course, and preventing FASD. What is your comfort level around that? 1, being very uncomfortable, 5, being very comfortable. Just give a minute for that. See lots of 4s, 5s, again, some 2s, which is awesome. I'm usually most excited about the 1s and 2s. Someone's doing half marks, and that's great. Thank you so much. And then our last one together today is, I know where to find evidence-based resources that I can learn more from or to share with my patients, clients, or participants to help prevent FASD. So specifically information about alcohol use during pregnancy and preventing FASD. What is your comfort level around that? Again, 1, being very uncomfortable. I don't know where to find that stuff. Or 5, being comfortable. And of course, we live in a society today where social media has such an impact on the information that's being shared with pregnant people. I often say, our biggest competitor with evidence-based information is TikTok right now with the younger population. So it's really important for us to be able to support pregnant people and people who are about to get pregnant to be able to find and discern what is evidence-based information and what did just Sally say on TikTok, and how can I figure out if that's true or not. So lots of 4s and 5s, and living in a society where we have lots of information being shared on evidence-based resources, I'm not surprised by the 4s and 5s. That's great. Thanks so much for participating. So, of course, Christy read for like 4 minutes about me, but I'm not going to tell you that stuff. What I'm going to tell you is I'm currently the executive director of BCA POP, so BC Association of Pregnancy Outreach Programs. I've been here since 2018, which means I'm in my 7th year and time has flown by. This is absolutely my dream job, and I hope to stay here until I retire one day. My background, as Christy said, is a registered nurse with a perinatal specialty. Combination for sure working would be my favorite combination in acute care is labor and delivery and withdrawal management at the same time. So I had done that in Kamloops. I went back to school later in life. I did not graduate till 2016. Previous to that, I was a co-founder and executive director of a peer-driven organization for families struggling with substance use and trying to overcome it, and a founder of Mothers for Recovery support group in 2005. So going way back. Most important role I have is I am a mom of two. So I have two ladies. They are getting older. They are now adults, 19 and 20. One is in third year nursing, and the other one is doing her ECE and works in a daycare full time. So they grew up to be contributing members of society. And with that, I think the important piece about sharing that is I'm also a person with lived experience. So I have lived experience of using through both of those pregnancies, one in the downtown east side of Vancouver, accessing really great evidence-informed resources like Sheway and First Square at BC Women's Hospital. I lived in First Square during my first pregnancy. And then I also have the experience of using through a pregnancy in Kamloops, BC. So I have had the gift of accessing resources, having to overcome a substance use disorder. And going into this year, it's 2025. So I'm going into 18 years of abstinence. And that abstinence for me really allows me to have kept parenting my children and to influence them in a good way, as well as to create a career, right? So sometimes I do a lot of training with nurses in particular. Sometimes people will just be like, oh, I needed to hear that there's really successful stories. And there's really successful stories across the country, across Canada. There's families who are doing the work of overcoming alcohol use disorder, substance use disorder, becoming safe parents, becoming really contributing members of society, continuing on journeys. Whether people go to school or not, or own a house or own a car, doesn't really matter to me. What matters to me most is that we see families who are overcoming barriers to wellness, and we recognize that it happens every single day and that it's possible. We need to be able to carry a seed of hope in order to do good work. So that's my purpose when I share the fact that, yes, I'm a nurse, yes, I went to school, blah, blah, blah. But where my passion really comes from was accessing best evidence-based and best practice programs and bed-based programs. And I had a really, really beautiful professional support. And my aim in my work, and will be until the day I probably pass away, would be to influence other perinatal professionals to use their power in a really positive way, to influence families in a really, really great way. And to know that all of us in this room have that power would be my intent. So I'm going to do a tiny bit of review first, and this really talks about stigma towards different substances, and how with FASD prevention, how unique the information specifically around alcohol use and the risks around it are so different than the other substances we're seeing being used during pregnancy, and how that kind of plays out in society today. This picture is one of my favorite pictures. It's of First Square here in BC. So a acute care unit specifically for pregnant people affected by substance use to stabilize. It had opened in 2003. Personally, I was very lucky because I became pregnant in 2003, and then I lived there for quite a while. The program, the medical parameters of First Square has changed quite a bit since I lived there. That being said, beautiful, beautiful program. And I always want to give props to Ron Abraham, Sarah Payne, and Georgia, the three people that really made First Square happen and really made it come to life for people like me who were living in the downtown east side and pregnant and using substances. So I always love sharing this picture. All of those photos there are from this volunteer photographer who comes in and does really professional printed photos for all the pregnant people and their bellies, or newly parenting people, or newly postpartum people and their babies. Really prized possession. And we're going to talk about why that's so important, why that exact picture is so important when we get to attachment and safety tasks today. All right. So alcohol, the main reason we're all here today, how do we prevent FASD? How do we support people to reduce and abstain from their alcohol use? What does that look like in pregnancy? What do we share with people? So a really great sentence I love, love, love to teach. And I definitely learned this from Nancy Poole, the doctor and lead for the Center of Excellence for Women's Health. Greatest sentence to have in your back pocket is it's safest not to. So when it comes to alcohol, when we talk about pregnancy, we're not going to talk about chest feeding, breastfeeding today, but I would use that sentence then. I would use this sentence for safe parenting. I would use this sentence for many things. We could use it in prenatal nutrition. It's safest not to. So when we're talking about harm reduction language and harm reduction strategies, we all know that we want to come from a non-judgmental approach. But if I were to ask 5 professionals, what does that mean? Half of them wouldn't know what that means. What does that actually mean to come across non-judgmental? So if I were to say a sentence to a pregnant person already struggling with alcohol use disorder, it can be really harmful for your baby, for you to continue drinking. That sounds very different than it's safest not to drink alcohol during pregnancy. When I start my sentence as it's safest not to use alcohol during pregnancy, I get to put a comma at that end of the sentence. And I also get to say, but if you're struggling with alcohol use during pregnancy, I'm here to support you. There's options, there's hope. I have this list of resources. Make it into any sentence you want. When this sentence starts rolling off your tongue, suddenly you're building a connection with your pregnant person in front of you because you're saying, I'm sharing the evidence-based information. It's true. It's safest not to drink during alcohol, during pregnancy. However, I also understand this may be the most difficult thing for you to abstain from alcohol use during pregnancy, and that you may require some really intensive support. Really, really great sentence, and you're going to hear it a few times as we go over all the substances and compare stigma. So there's no known safe amount that's been identified in research. Anytime we're sharing evidence-based information, that's a really important thing to share. And usually if I was in a group, I would say, why is that an important sentence to share? There's no known safe amount. Well, again, what are we up against? We're up against TikTok. We're up against Reels. We're up against unfounded websites of people saying things like what? And I would love, I won't do it right now, but normally in a group, I would say, what are the things that your participants say about alcohol or cannabis or blah, blah, blah. The things people hear on social media about alcohol is that 1 glass of wine a day is fine, 1 beer a week, a drink in a certain trimester. You can throw your own into the chat right now. I will be downloading the chat later, so I actually want to read them. I get other ideas of what you're hearing currently in today's day and age from your participants that they're hearing on social media. So we want to be able to combat that with research has not identified any safe amount. We want to prepare and arm our participants, clients, or patients to be able to engage in social media, which is such a better strategy than saying don't take information from social media, because that doesn't work. That's very similar to don't do drugs, which we know also didn't work in the 80s. If you were my age and you saw the commercials with the cracked egg and this is your brain on drugs, we all know that didn't work. So there's no safe amount of alcohol that's been identified in research. I'm just going to check my time because we all know I talked for a long time, so I'm going to try to stay on track. Alcohol is carried to the fetus through the bloodstream and placenta. Again, this is another myth. So really important work when I'm a professional, I'm working in the hospital, I'm working in detox. I get to bust myths. That's a really important role for me as a professional. My role is not to tell people what to do. My role is to share evidence-based information and a menu of services, and it's the participant's role to listen to that information and apply it or not, and to choose those services or to decline those services. I'm not here to force anyone to do anything. So alcohol is carried through to the fetus through the bloodstream and the placenta. This is another myth, really, really strong Peer-to-peer sharing. If you've ever had kids and you've grown them and they've gone through teenagehood, you know that there becomes this time in teenagers where their peers sharing information is more respected than your parenting information. This also rings true in the parenting or pregnant community. So people are hearing information from other pregnant people, other parents, other, your grandma. Like, let's talk about peers. My grandma has some really insane advice for me when I'm pregnant, and I actually remember it from 20 years ago. So we're busting the myth, and the myth that's often carried through is the placenta is a filter. I'm sure most of us has heard this. The placenta is amazing if you've ever studied it. It's wondrous. It's lovely. It's got all these really, really great qualities that are for the protection of the fetus, let's say. But what it isn't doing is it is not filtering out alcohol or any other substance. It's not doing that. So there's an opportunity for busting me. I will always say information sharing. Professionals love to have information about risks, benefits, blah, blah, blah. I would never sit someone down if they had alcohol use disorder. So this is not someone who is socially drinking, found out they were pregnant, stopped using alcohol. If I have a person in front of me who's pregnant with alcohol use disorder, they are physically dependent. They have an addiction cycle going. They have a diagnosis. It is a disease of the brain and body. If they are sitting in front of me, I would never sit down and run through all of these risks. I would just use little learning opportunities to be able to bust myths like, oh, have you ever heard this on social media? Or have any of your friends told you this? That peer-to-peer group, really, really important, and says a lot of things and shares a lot of things. And that really comes from my personal experience and thinking back to what was shared with me when I was pregnant from other people who were using, who were also pregnant or not pregnant. So those peer-to-peer sharing is so strong. So we can combat that as a professional. Of course, alcohol use in pregnancy can lead to FASD. The important, and I am not an expert by any means in FASD, so the important myth to bust here that sometimes you will hear, and we hear it from other professionals as well. People ask my opinion on it, and I don't have an opinion because why do I not have an opinion? Because I have not taken the time, I guess, to explore it further. I used Canadian FASD, evidence-informed information, but the myth you're probably thinking of right now when we talk about FASD itself, that you will hear from another professional or from a pregnant person, is like, I heard in the UK that FASD doesn't exist. So we want to be prepared for that. We want to be prepared with our evidence-based research. We want to be prepared. And at the end of today, we're going to go over some really beautiful Canadian resources, some from Christie's organization, some that BCA Pop has listed. So you can dig into that if that feels like something you want to be more prepared for. All right, so FASD, of course, is a lifelong irreversible disorder that can include brain damage, vision and hearing problems, slow growth, birth defects, and or heart problems. Again, I'm not an expert in FASD, so I'm not going to go further on what FASD is because I know we have an audience here from the Prevention Institute who likely is already very familiar with that. But what I do want to point out, the most important key words here is that the risk of using any amount of alcohol during any time in pregnancy, and yes, there's higher risk and lower risk periods, but we can't ever predict 100% safety. That's why it's 0 and 9, right? If you used to get those bracelets, 0 and 9 bracelets. So the important words in the risks is irreversible, lifelong disorder. So we cannot treat it. We cannot give a medication to get rid of it. We cannot cure it. Once a fetus is exposed to alcohol that has physically change them and chemically change them in a way that is going to lead to an FASD diagnosis, we cannot undo that. Really, really important piece. So alcohol, when we're talking about substances during substance use during pregnancy, alcohol is the only teratogenic, which means it is physically changing the way the body and the brain is forming. That's the most important take-home message about alcohol use during pregnancy. And what's so insane or crazy or shocking about that, of course, is that alcohol use in Canada, so alcohol is legal, of course. Alcohol is socially acceptable. I would not say alcohol use during pregnancy is socially acceptable in all circles, but in some it is. That's important to know. But what's really interesting is if you were a person, let's say in Canada, who did let's say you're 6 weeks pregnant, you find out you're pregnant and you were like, oh crap, like I went to the bar last week, I got really drunk, blah, blah, blah. Most people are going to say, and it can be different, of course, there's variances from this, but most people are going to say, it's okay, don't worry about it, just don't drink again. We are not going to find that same reaction if someone said, oh, I'm pregnant, I just found out, it's been 8 weeks, I've been using cocaine. You're not going to find that same reaction of like, oh, it's okay. So what we need to be thinking about is how the stigma of illicit substances, let's call them for the sake of this, actually is working against us as a society because alcohol is more socially acceptable. That being said, alcohol use during pregnancy is the only substance that can lead to a lifelong disorder, that can be a diagnosed lifelong disorder. So we need to be really thinking about, as professionals, how do we change the stigma within society? And I'll have an example about harm reduction and how that works as well. So we also want to be sure to be aware that alcohol use in pregnancy can also lead to miscarriage, stillbirth, premature birth, or low birth weight. Of course, risks during pregnancy of a substance. There are risks to any medication we take. There are risks to our SSRIs, often used for depression. There are risks to eating certain fishes and cheese and blah, blah, blah. There are risks to everything. So a risk does not mean it's going to happen, but a risk means it could happen because of our alcohol use. So our take-home message from alcohol in pregnancy is that it's safest not to drink any alcohol during pregnancy, but if you're struggling, we can support people. And that alcohol use during pregnancy is a teratogenic. It's the only substance that can lead to a lifelong, irreversible disability. Okay? That one we spent a lot of time on, and I'm not going to spend a ton of time on the other substances I go over, but I just want to give you a comparison for stigma. So I always use alcohol, nicotine, cannabis stimulants, and opioids when I'm talking about pregnancy, chest feeding, breastfeeding, blah, blah, blah. So we're just going to run through the rest really quick so we can compare them. So again, it's safest not to use nicotine during pregnancy. The placenta, again, is not protecting the fetus or filtering out any of those chemicals or nicotine, which is the drug or substance. It's the stimulant in cigarettes that can affect babies. And tobacco use during pregnancy or nicotine use during pregnancy can result in premature birth, stillbirth, or low birth weight. What's interesting about that and what often puts risks of substance use during pregnancy into perspective is that many of us, if you're around my age, so I'm in my early 40s, we're exposed, of course, to nicotine and tobacco, utero, postpartum, blah, blah, blah. So, of course, there is risks. Did they often happen? No. But we want to ensure that we are sharing the evidence-based risks. And I shouldn't say they don't often happen. I want to take that sentence back. But we want to be sure we aren't fear-mongering our clients when they are using substances. We really want to move in a direction of harm reduction. I'm going to talk about what that looks like. So cannabis, same sentence. It's safest not to use cannabis during pregnancy. Christy, I'm going to send you a sheet I did yesterday of all the resources we use. So no one has to worry about taking notes. If you're madly taking notes, you're going to have access to all of this information. What's always unique about THC that I think is interesting to share is that THC, so the chemical in cannabis that gets us high, is stored in fat cells, and that's what makes it really unique. So THC is stored in our fat cells. If we're talking about a woman, it's also stored in our breast tissue. So when we get to chest and breastfeeding, maybe another day, another time, or at our PSU training in a couple of weeks, we'll talk about why that's really important. But that's what makes THC unique. So the risks, cannabis use during pregnancy, again, lower birth weight and can affect the baby's mental health later in life. And there's lots of research going on right now, of course, around pregnancy and cannabis use. And I'm sure we've all seen a spike in disclosure about cannabis use during pregnancy since it's been legalized. And again, we want to think about the legalization, social acceptance, because that affects stigma and affects what people are doing. Stimulants is going to include our cocaine and amphetamines and methamphetamines. So our crystal meth, our coke, our crack cocaine. And it is safest not to use any stimulants, of course, during pregnancy because there's no known safe amount. And the risk factors, because stimulants are similar to nicotine in that it's a vasoconstrictor. So my vasoconstrictors mean like when I had a baby, let's say it really holds back nutrients and oxygen's getting to that baby because it's a vasoconstrictor. So stimulant use during pregnancy can increase the risk of miscarriage, placental abruption, stillbirth, preterm rupture of membranes, premature birth, and intrauterine growth restriction. It can also cause low birth weight. It's really interesting that stimulant use, and if we go back to our nicotine, has very similar risk factors for a baby, for a fetus. So we want to really, again, not get into fear mongering or overcompensating for the risk for someone who's sitting in front of us with substance use disorder or alcohol use disorder. I always say if someone has an addiction or substance use disorder or alcohol use disorder, information is not actually the answer. We will talk about what the answer is, but information at that point is not the answer. Where information is really, really important is in prevention. So if I'm working in public health and I'm doing prevention with women, let's say childbearing age, my kid's age, 19, 20, they're able to get pregnant, they socially use alcohol, that would be a prevention strategy where I'm sharing information that can impact their choices in the future. But if I have someone sitting in front of me who is 2 months pregnant, they have alcohol use disorder, going through the list of risks is not going to be the answer to the problem. Because if it was, they would have already stopped, or they would stop the first time someone tells them. So peppering them with risks for 9 months is not going to be the solution. And then last but not least, opioids, super, super interesting. So it's safest not to use any opioids during pregnancy, of course, prescription or non-prescription. Chemical is a chemical is a chemical. And untreated, non-prescribed opioid use. So let's say using fentanyl or heroin that I was buying from a dope house during pregnancy, and having that inconsistent amount is what is a risk to a pregnant person, which is interesting. Now, what we will see through everything except alcohol, and this is the take-home point around this. So alcohol, again, is the only teratogenic that physically changes the way the brain, heart, and other parts of the body develop in utero, so inside of the womb. None of these other substances do that. All of these other substances can have effects like withdrawal symptoms. So let's say I have a baby who's exposed to cocaine or fentanyl, street fentanyl, let's even call it for a second. And fentanyl that's purchased on the street, not street fentanyl. That language wasn't my preference. So if we have a pregnant person who is using stimulants or opioids, and they're having inconsistent amounts, and they're being affected by all the other things, poverty, not eating properly, blah blah blah, and then they have a baby and that baby experiences withdrawal symptoms, our acute care system can treat those time-limited withdrawal symptoms. I'm not saying there aren't any other long-term effects for babies exposed to substances other than alcohol, but the argument, if you get into the research, is what are the other things that are affecting that fetus? Lack of nutrition, violence, sex trade, exposure to STIs is a big one. Not having safe housing, stress, blah, blah, blah. There's so many co-founding factors that you can't tease out what is a result from the substance use during pregnancy versus the environment, the situation, the social determinants of health. So those are really, really different things, right? So we want to be sure that we understand that with other substances, and especially when we talk about a baby, a newly born baby experiencing withdrawal, that can be treated with medications, eat, sleep, console, mother or parent is the first line of treatment. We can do all of those things. We cannot do that once there's alcohol exposure because we cannot treat FASD. And those are kind of the take-home messages for pregnant people, is the difference between all those substances. So when we talk about harm reduction, I love to tell a tiny story about when I got pregnant. So I got pregnant in 2003. I did not know I was pregnant for a really long time. And the purpose of this is to just illustrate what a really great evidence-based informed professional can do to really change someone's life. So when I found out I was pregnant, I ended up accessing Sheway, which is one of our pregnancy outreach programs and one of our program members here in BC. It is a pregnancy outreach program opened Monday to Friday. It's kind of a, I don't know, a 10 to 4 sort of thing. And you can go there and drop in and you can eat and access donations and blah, blah, blah. And upstairs, there's physicians and nurses. So every day in my time, there was a physician there. It was one of 3, either a midwife or a physician. It was Sarah, Ron, or Georgia at the time. So when I had found out I was pregnant at the downtown Eastside Health Center, they were like, well, you need to go to Sheway. So I walked up to Sheway 2 blocks, walked in the door. And we'll expand on the story another time in 2 weeks' time when we do our PSU 101 training with the 30 people who are doing that. But I got to see the physician. I was well past a date for an abortion, which I did not know at that time. But for me, when I had found out I was pregnant, and my drug of choice for sure is crack cocaine, so it's stimulants. When I found out I was pregnant, I instantly thought I needed an abortion because I instantly thought that my baby was going to be deformed because I was using cocaine. I didn't think there was any way around that. So when I accessed Sheway, I actually went for to access an abortion thinking there's no way that this little body can be complete. I am so lucky I had a professional who was well versed in addictions and pregnancy, so perinatal substance use. And Ron was working that day, Ron Abrahams, Dr. Abrahams. And I walked in, I came from the bathroom, I had just done a hit of dope, whatever. And he asked me, like, oh, like, what's going on? And I said, I'm pregnant. I need an abortion, though. Instantly, I need an abortion. I'm doing so much dope. And he said, what are you using? And I said, crack cocaine. And he said, oh, sir. And he said, oh, do you think you can reduce your use of that? And I said, no, I just did a hit in your bathroom. There's no way. And I was definitely crying. Like, I was super upset. This was the first time I had been pregnant in my life. I was 19 years old. Definitely living in our most poverty-stricken postal code in Canada and living a life completely surrounded around addiction. So crying, and I said, there's no way I can quit. I just did a hit in your bathroom. And he said, oh, okay. Well, using cocaine is not a reason to get an abortion. If you want an abortion because you don't want to be pregnant, I will give you the referral. But using alone is not a reason to get an abortion. I deliver babies every day who are exposed to crack cocaine and do really, really well. And I just remember, shoulders dropping. this story is emotional for me. Shoulders dropping and just be like, it never occurred to me that that was what a doctor was about to say to me, that like parenting is still an option. So Ron was brilliant, and Ron's retired now, but looking back, and I've put all these pieces together over the years, right, of reading in that. Ron was absolutely brilliant in that appointment. He did a whole bunch of things, but one of the things he did at that moment is said, cocaine use during a pregnancy, any substance use during a pregnancy is not a reason to have an abortion. Not wanting to be pregnant is, and I will give you that referral, but why don't you take some time to think about that? And then, like I said, he asked me, can you reduce your use of that drug, which for me was a stimulant, right? Crack cocaine. I said no. He was brilliant enough to have the next question ready, which was, okay, can you just not use alcohol till tomorrow and come back and see me? And I instantly perked up and was like, oh, yes, I can. Like, I cannot use alcohol. And the truth was, he knew, obviously, about FASD prevention. So it was actually, if I wasn't able to quit using substances, it was most important for me to not use alcohol because, of course, it can lead to FASD. He also knew, being someone who was experienced in substance use, he knew that people who use stimulants often don't use depressants. So he knew he was creating a goal for me that I was going to be able to achieve. And he followed it up with, and can you come back and see me tomorrow? So not, can you make an appointment in a week? Can you come back in a month? Let's think about normal prenatal care pathways. It was, can you come back and see me tomorrow and we'll talk about this? So he created this goal, which would have increased my capacity of, yes, I can do that. He knew that I could abstain from alcohol for 24 hours and that he was setting me up for success. Beautiful, beautiful, beautiful. So if you can imagine, if someone like myself, we're always going to use me as the example. You can imagine someone like myself going into other care professionals, other acute centers, places who don't work with pregnant people who are using substances every single day. What do you think the reaction would be if I said, I'm using crack cocaine every day and I need an abortion? Often the reaction is absolutely, I'll give you that referral instantly. Not even any thought to, that may not be a valid reason, or we may want to talk this through to carry out this pregnancy, and that there's things we can do. So lucky that I had a professional who knew what they were doing, also knew about harm reduction, that the most important thing that I abstained from at that point was alcohol. So blessed to have that part of my story, right? And then able to start building capacity within myself and goals and blah, blah, blah. And I mean, it took years from that point. And I always like to point out timelines, because professionals can get, this is hard work, right? We can get, what is that? We can get burnt out. We can get really lose our hope around people who are using during pregnancy or struggling with alcohol use disorder during pregnancy, or perhaps relapse later when they're parenting. So we absolutely need to have that hope. Hope is part of what we do. All right. Strategies to support. So I love pulling from different research and evidence-based sources. We have, I think, 2 that we're going to use today to talk about practice. So how can we improve our practice? How can we get comfortable? Where do we need to get more comfortable? Where are we already comfortable and doing really, really great? So the care principles for pregnant people using substances, this is actually pulled from the treatment of opioid use disorder. Really great guidelines from the BC Centre of Substance Use. It will be on the resource list that I share with you. Really cool, because it applies to all people, including people who are using alcohol during pregnancy. The point of our discussion today is, how do we promote FASD prevention when someone actually has alcohol use disorder? So we're not talking about, again, the people who are socially drinking, where we need to do prevention strategies in public health and schools and blah, blah, blah. We're talking about, what about the people who have alcohol use disorder? What are our harm reduction strategies? How are we going to approach that? So I love this set of care principles that are so great. They apply to all people using substances, even alcohol. And the actual treatment guideline, I know it's going through a refresh right now, which is really exciting. So we'll update on our website when that refresh comes out. So we're just going to talk about these first. So first care principle is establishing a trusting and collaborative relationship with a patient. Also assuring confidentiality. So I am not sure what the legalities are in Saskatchewan or whichever province you are calling in from today, but here in British Columbia, in 2018, we had the abolishment of what's called birth alerts. So people were reporting pregnant people who were using alcohol and other substances. MCFD was getting involved. These faxes would go out, and MCFD would show up as soon as these pregnant people were delivering because of this birth alert system. So that was abolished for us in 2018. Definitely, it was rooted in systematic racism and really used as a tool over the years that led to the overrepresentation of Indigenous children in the care of child welfare. So confidentiality to this point, at least for us in British Columbia, also includes that there is no duty to report a pregnant person who is using any substances, including alcohol, unless they are caring for another child at home. So if we have a pregnant person who's just using alcohol, they're struggling with it, but they are not caring for another child, we can assure them that we are not going to report them. However, we are also offering the opportunity for what's called voluntary engagement. So that's the legalities in BC. Voluntary engagement is where MCFD or a delegated agency really wants to connect with a pregnant person and start services early, but the pregnant person has to give consent to that. The other thing I would say about that is that as a professional who's not a child welfare worker, I would never want to make promises. So promises we want to avoid when connecting a pregnant person for any sort of voluntary services with child welfare. Promises I would avoid would be promising the outcome, like this for sure will go well. This will prevent a child or a baby from being apprehended when it's born. I would never make promises for that because the truth is they may not get along with the social worker. Their baby may still be apprehended, and I cannot prevent that. What I can do, again, my job is to offer evidence-based information as a nurse and a menu of services, and it's their job to choose. So I like to offer, yes, it could be helpful. And yes, there are other people who said it was harmful. Those are all true things. So a trusting and collaborative relationship, it's really important that we offer that full menu of services and evidence-based information that really increases the confidence in our patient, client, or participant in us. So I want to ensure that a participant knows that I know what I'm talking about. I'm offering harm reduction. I'm not set on one way. It's not about, well, you need to quit alcohol use or all these things will happen. I want to start the conversation with, are you struggling with alcohol use? And if you are, I'm totally here to help you. So collaborative and trusting relationship is actually probably the most important thing. It's why it's number one above all else. You will notice number one is not make sure you share all of the harms about alcohol use during pregnancy. And for some people, that's really, really hard who work in professional environments or science-based people, type A personalities, because we get really caught up on, but the risks, we know any amount of alcohol could cause FASD. We need them to quit drinking, and we start getting really caught up on that. And we'll talk about how to bring that back into perspective and move with the client instead of against the client. Number two is about being trauma-informed and culturally safe. Trauma-informed, I love the work that Center of Excellence does, and Nancy's done a lot of writing around trauma-informed ways of working, which is very different than trauma-specific services. And the only time I ever realized that difference was reading and doing research or creating some of this content years ago with their trauma-informed practice guide, and I'll give you a link to that. It really is able to tease out a trauma-specific service would be something like I'm going to sexual assault counseling. The trauma-informed way of working is about realizing that most of the people we work with, if we're working with a marginalized population, will have some experience of trauma, whether they identify it or not. So that influences the way I work with everyone, and I don't need anyone to self-disclose their trauma to me in order for me to work in trauma-informed ways. I work in trauma-informed ways all of the time to ensure that my patients are experiencing trauma-informed care. So it's not an exchange of stories. It's not a need to know. People get to keep their privacy if they want to. And I'm still working in a trauma-informed way. Super cool way of looking at it, because we all can work in trauma-informed ways, which is different than being like a trauma counselor. Those are two very, very different things. And then culturally safe practice. We'll talk about this again later, but we've been on a journey at BCA POP towards our commitment to reconciliation. And I love what I heard from at actually the Visioning Forum in 2019. There was a presenter there here in BC, and she talked about how culturally safe care is up to the patient. So not up to me to say I provided culturally safe care or practice. It's up for the patient, client, or participant to say they experience culturally safe care. Really unique way to look at it. It means that all we can do as professionals is aim for culturally safe care. I cannot guarantee that every person I'm interacting with has that perception. And when they don't have that experience, I need to learn from that experience and get feedback on how to improve. Okay. Number 3, making necessary referrals to secure social determinants of health. We'll see this on a couple of the different slides, social determinants of health. And this ties back to when I was speaking about, let's use my own kid as an example. They know I do this now, so we're good. So I have 2 kids who were both exposed in utero or had prenatal exposure to stimulants, to crack cocaine. As they went on in life, let's pretend one of them struggled maybe with depression at 14 years old. Let's just pretend. There is no way to tease out whether that came from, I was starving during that pregnancy, I used substances during that pregnancy, I experienced a lot of violence during that pregnancy. There's no way, I'm just going to use those 3 examples that are very vanilla. There's no way to tease out between those 3 things what may have contributed to that depression. There's always also no way to tease out, it's my child. I have a history of depression. Did I just pass that on to her? Or when we look at environment, postpartum, and parenting, did I cause something? Did my parenting, did our environment cause something in some way that led to that depression? Also, my kids' dad passed away when they were in kindergarten and grade 1. What influence does that have on their end result as adults, as teenagers, as they go on in life? I don't know if you've ever experienced this, but for me, when I think about things that have happened in my life, and there was a lot of things that happened during my substance use disorder, my active addiction. Every time my kids get older, it's like a new layer gets removed and I experience something new in relation to those past experiences. So it's really interesting to look at children who were prenatally exposed and to talk about what could have contributed to either their resiliency or some of the issues that they need to deal with and overcome. Super interesting to look at. But what is interesting, so flipping back to this number 3, making necessary referrals and secure social determinants of health. A really easy way to remember what this means is if you are working with a pregnant person, let's say Sally, and she says, I cannot reduce my alcohol use. I'm too dependent right now. And we're going to accept that for today. We're not going to go into a long laundry list of risks if she doesn't quit today. What instead we're instantly going to do is go on to the other referrals. So if you can improve nutritional status, which is my favorite one, offering people snacks, drinks, food banks, meals, if we can improve someone's nutrition status, prenatal vitamin, all of those really great things that many of us are doing, if we do nothing else but improve those social determinants of health and those other factors in health, we will be contributing to better outcomes. We need to be able in the moment to ask, can you reduce or abstain today? If the answer is no, we have to be able to move on to basically plan B, where many professionals get tripped up, or new professionals or people who aren't used to working in addictions, is if the patient says, like, I'm not willing to go to treatment. I'm not willing to reduce my use. I can't reduce my use. Or they say they're going to, and then they relapse, blah, blah, blah. It's almost like a professional will get stuck then. Well, if we're not going to reduce use, I don't know what else to do. And I don't think it's that people don't want to do well, professionals. I think it's that they don't know what to do. And that's where I was so lucky. And it ties back to my story about Ron. When I said, I cannot reduce my crack cocaine use, he instantly had the next part of the conversation ready. And often that's where we're seeing it missing in practice is what are you going to do if today we're not abstaining or reducing? And we'll talk about different stages of change and how to match our professional goals to that. All right, so making the necessary referrals. If someone says, I cannot reduce my alcohol use today, I can to 50%, let's even say, that's fantastic. But what else can I be doing? Can I be connecting someone to food, better housing? The most under referred to resource is peer support groups. So think about and I don't care which one, 12 steps, your smart recovery, your mothers for recovery, your any sort of recovery oriented harm reduction group for pregnant people would be a really, really great step in the right direction towards moving on that continuum towards abstinence and harm reduction. I love talking about the referrals to peer support groups for sure. Number 4, integrated and individualized care programs. I think what I love talking most about individualized care programs was the realization. So I was working with families really early in my recovery, like even before I was fully abstinent, I would say. And a peer-driven organization. And what I really learned over the years, just going as a support person with families to child welfare meetings, and I could talk about techniques to work with this all day long, but we won't. But what I learned at one point, about 5 years, I would say, into my very first job, was the importance of recognizing traditional healing and how that wasn't being recognized during the plan for child welfare and safety. So this would be the same for a pregnant person. We need to ensure, and this goes back to culturally safe practice, that we are looking at the individual, we are offering that full menu of services, and we are letting them select what feels good for them to try first. It doesn't mean it has to be successful. We also need to have a plan B after that. But we want to ensure, examples I can give off the top of my head, I would ask someone, are they connected to their community? If I'm talking about a person who identifies as Indigenous, is there any beading, sweats, smudging, traditional healing? And these aren't things I'm an expert in, so I need to be the one who's asking and doing the learning. I could never come to a person, either a person who identifies as Indigenous or from another culture, with this menu of services that is strict. I need to do the learning first as the professional, because every person is different, even within the same culture. We need to know what the goals are that we have no idea that exist. I was with a woman in First Square when I lived there, and it was so beautiful. She had 5 children, and she, during her pregnancy, made, is it a baby board? I'm going to call it a baby board, and I hope it's not a mistake. She made beautiful baby boards that would go on her back for her baby, and they were sewn with hide, and they were gorgeous, and it was her art, and it was her healing, and it was being recognized as her healing, and I had never seen that before. So I learned from that I need to be aware there are healing practices that take people from substance use disorder or alcohol use disorder into recovery that I don't even know if exist. And if I am pushing my very I am a person who is Caucasian, who has experienced white privilege for sure. And if I am pushing my colonized Western medicine ideas, which are the only ideas I grew up with and learned, let's say in nursing school, if I'm pushing those ideas, I'm actually creating harm when I'm not first asking what would be the ideal healing practices. Where have you learned healing from? Are there elders involved? There's so much discussion we can have. And if you think about what I'm talking about, asking people and learning from people and learning from our patients, and to get away from this idea that I'm the professional with all of the golden knowledge, it really comes back to number one, where I'm creating a trusting and collaborative relationship. My participant can see that I'm willing to make an individualized plan. I'm willing to ask, I'm willing to learn, and I'm not pretending I know everything. Because even if I'm a person who's experienced addiction and recovery, my experience is different than everyone else's. Everyone is a unique individual, and what worked for me absolutely may not work for that person. So I need to be learning, and learning and asking questions is the first part of making individualized care plans. And then the last one, access to a full scope of harm reduction supplies and services. When we were talking about alcohol in particular, this can be hard to wrap our minds around. So let's just sit with an uncomfortable idea if this is uncomfortable for you. The idea, the principle, is that every pregnant person using a substance, let's use alcohol and fentanyl that's illicit. So illicit fentanyl and alcohol is an example. Every pregnant person who are using those substances have a right to the same harm reduction supplies and services as general population. So what are examples of this? I had a phone call once from a supervised consumption site, and it was very, very sweet. It was very innocent. It was very good intentions. They wanted to make sure they knew what they were doing as the professional. And they said, Heather, this pregnant person just came onto the site. What do I do? Do I give them supplies? Do I support them? What do I do? And this was a very small town. So this wasn't like Insight at Main and Hastings where they're doing this all day. It was a new nurse in her role. And I was like, oh, the principle of care is that all pregnant people have access to the same harm reduction supplies. And that made it very easy and very clear for her. She already knew how to do her job, which was harm reduction. She got to apply harm reduction strategies to the pregnant population. She was already an expert in her job. She knew exactly what to do. She just needed a confirmation that that was the right thing to do, and we don't need to withhold or do anything different. Really important concept. Now let's talk about alcohol in that same idea. What can be hard for some people? There's been pilot projects throughout our province. We even have controlled drinking pilot projects. We have lower risk guidelines in Canada. We have harm reduction programs. Pregnant people who are using alcohol still have the same right to all of those things. And that can be really hard for professionals to accept when it comes to reducing the alcohol use, but it could still lead to FASD. And what we need to get out of the way of is this is not our story. Pregnant people have the right to live at risk. Alcohol use disorder makes life hard. People struggling with alcohol use disorder and substance use disorder who want to go into recovery, it is likely the hardest thing they'll ever do in their life. So for me, and I learned that, I've done some cool things in my life. I've made some big mistakes. I've done a variety of things. I've gotten a degree, blah, blah, blah. Hardest thing I've ever done in my life. Sorry. Was to get abstinent. Worst feeling in the world, being pregnant and not being able to stop using whatever your substance of choice is. So really, really recognizing that harm reduction is still moving us in the right direction and that it can be uncomfortable. And again, we'll talk about the stages of change, okay? I think that's where I'm going to leave this slide and just check my time. All right. So when we're talking about alcohol use disorder and pregnancy, what is harm reduction related to perinatal care? So related to pregnancy. Really great sentence to remember. It's everything except the use of substances. So again, this is going back to my difficult situation of pregnant person saying they can't reduce their alcohol use today or saying they will and relapsing. What else can we work on? We can work on everything except the use of substances. We can work on food, housing, reducing violence, ensuring we aren't transmitting sexually transmitted infections, bloodborne infections. Like we can work on so much, including attachment tasks as well, outside the actual substance use. And that's where a lot of professionals can get uncomfortable. And that's okay. It's natural. And what does recovery mean? So just always a quick note on if someone comes in and they are pregnant and they say they're in recovery or they want to be in recovery, they're aiming for recovery, they were in recovery, always asking again, going back to people are the expert on their own life. What does that mean to you? So I've had pregnant people where that means they are smoking cocaine instead of injecting cocaine, and they were very proud of that. That's what they meant recovery meant, and that they identified as being in recovery. Some people, of course, alcohol use, a more common harm reduction strategy specifically for alcohol use might be the use of cannabis during pregnancy instead of using alcohol. Again, because cannabis is not a teratogenic and going to lead to FASD, if we're just talking about FASD and which one pros and cons, it actually makes sense that someone will choose to smoke cannabis throughout their pregnancy instead of use alcohol. Can we get comfortable with that gray area? It's really up to you. So really asking people and asking people to teach you. It's a really great way to start a relationship with someone is asking people about their perspectives, their experiences, and what they think will work for them. We're so quick sometimes, depending on where we did our schooling for our professional, whatever your profession is, we're so quick to tell people what they should do. Taking a step back, building a relationship means we're asking people what to do. And that's where brief intervention training and motivational interviewing can be really, really helpful to start getting those words under our belt. When we talk about alcohol use, actually, I'm going to stop there for a sec. Christy and anyone, is there any questions before we keep going? Or comments?
No, there's none in the chat room.
Perfect. All right. I will keep going. Cycle of addiction. So when we talk about medical diagnosis of alcohol use, of course, it's alcohol use disorder or substance use disorder or opioid use disorder. So these are medical diagnoses and a disease of the mind and body that people can get diagnosed with. When we're talking about the cycle of addiction, we need to think about historically what that actually meant. So if someone is growing up, and of course as children, not using substances, what a cycle of addiction and what we're trying to undo is where someone either in their teenage years or their early adult years, they start with healthy coping skills. What are healthy coping skills? Or what are healthier coping skills? So again, harm reduction. Healthier coping skills can include things like taking a bath, going for a run, writing in a journal, listening to music, cooking, eating something, whatever that looks like. So all of us, before any sort of addiction cycle kicks in, at some point had healthier coping skills than the actual substance use itself. Then there comes an exposure to substances, and then this cycle begins. The cycle begins where more and more time is using the substance, such as alcohol, to cope with life. And we all know there's a variety of things someone can be coping with, and less time is being used to use the healthier coping skills. So that means that over time, for some people, especially people diagnosed with alcohol use disorder or substance use disorder, almost 100% of the time is accessing alcohol or other substances for a coping skill to cope with life. So that means we really need to remember that when we're asking someone or we're supporting someone to reduce their alcohol use during pregnancy, we actually have to undo those years of practice with alcohol use. They were practicing using alcohol to deal with life. Now we need to practice using other strategies, and we don't know which one's going to work in order to deal with life that is not alcohol. That takes time. If it took me 4 years to practice my addiction until I got to the place where I was using 24/7 in an area of Canada where it's really related to the drug trade, if that took 4 years, it actually means it's probably also going to take me 4 years to practice using that substance and to do it with some confidence. So we need to think it would be the same for like gaining weight and losing weight. If we talk about obesity, the idea is the same. If it took someone 15 years to, let's say, gain 100 pounds of obesity, it might take 15 years to lose that 100 pounds. We need to be mirroring in life. How much time did it take you to really solidify the skill? Addiction is a skill. It's not a positive one, but it is a skill that does have positive benefits. And then how much time do we need to practice being in recovery? It's a long, long timeline. And if we look at using we'll exploit my own story for the purposes. I got pregnant with my first child in 2003. And my last day of using in this lifetime was July 14th, 2007. That means 4 years of really, really hard work. There was another pregnancy in the middle. Really hard work of really wanting to not use substances until the day I was able to abstain for then, what's gone on to 18 years now. And of course, I'm never immune to a relapse, right? So that timeline, if we think about a timeline, and that was with really intensive, supportive professionals who were very experienced in addiction. I couldn't ask for better professionals. That was with gold standard treatments and interventions. It still took 4 years of practice for me to be able to not pick up my drug of choice. So when I'm talking to acute care nurses and that, or let's say pregnancy outreach workers or people who have a limited time supporting a pregnant population, it can feel really draining or really scary when people don't get it right away. But we really need to be realistic. If we are more realistic about the timelines of how long it takes to actually access recovery, abstinence, or harm reduction, then we are setting ourselves up for success and we will be more resilient in our jobs. We really need to get our expectations in check with how long it can take someone to move through the stages of change. All right, stages of change. So I love talking about this. So we're going to apply this specifically to alcohol use in early pregnancy. So we always want to note, this is where professionals and helping peers can get mixed up sometimes. Stages of change for alcohol use or substance use is not correlated to the stage of change that a pregnant person is in wanting to parent. Dr. Abraham's Ron was really great about that for me. When I told you about when I found out I was pregnant, he was able to separate out wanting an abortion because of substance use. Reason to get an abortion is not wanting to be pregnant. Reason to give up your child to adoption or child welfare is because you don't want to parent, not because you're using substances. So we need to separate out these two. Often what happens is they're being married together. What are some of the things we hear from some of our coworkers who just don't have the knowledge or experience? They might say something like, well, obviously they don't want to parent because they're still using, or obviously they didn't want this baby anyway, or obviously they're not really committed because they're still using. And that can feel natural, but if we're able to separate out the stage of change around me wanting to be a mother, for example, is completely separate from my stage of change and readiness of reducing, let's say, my alcohol use. Okay, two different things. So right now, what we're going to talk about in this section is our stage of change around alcohol use. We, of course, all know these stages. We've all done them in education or school, but we're going to dig in deep specifically around the alcohol use disorder or substance use disorder. So pre-contemplation, contemplation, preparation, action, and maintenance. What is interesting is that most professionals and helping peers are most happy to be in this action stage. But most of your pregnant people using substances are going to be in pre-contemplation or contemplation until the day of birth. I'm going to repeat that. Most of your participants, patients, or clients, it is natural for them, it is expected, it is realistic for them to be in the stage of change of pre-contemplation or contemplation until labor and delivery. That is what is natural. That is what you should expect. Most people want to see pregnant people, of course, in action stage, which feels great. And if it goes that way, that's fantastic. But if as a professional, all of your skills are only in action stage, which feels really good, then we want to be focusing on how do I get better at being a professional, supporting people who are in pre-contemplation or contemplation. That's where the magic happens. You get good in those first two stages, and you're going to see better outcomes for the pregnant people that you're supporting, as well as their babies. So let's talk about what it looks like. Pre-contemplation, the person who's using alcohol in front of us is not aware and or in denial of the negative impacts of their alcohol use. What it looks like from a professional perspective, what it looks like is it looks like sometimes that they're lying to you. It might look like they don't care about their baby. It might look like they don't want to parent. That's what perception might look like if we're looking at a pregnant person who's actively using alcohol. What it feels like as a professional is it can feel hopeless. People will say, I'm just so scared for her. I'm scared for the baby. I remember my mom saying that. She was just so scared for the baby. She wanted the baby to come out well, right? It can feel really frustrating to watch someone who's drinking denying that they have a drinking problem. That's a very frustrating moment. But if we understand that this is a natural part of pre-contemplation, we don't take it personal. We understand this is expected. We understand this is a coping skill. We may feel angry with the patient about their choices, and choices, of course, is in why do I not know what air quotations are called? Quotations. We might feel angry with their choices while they're pregnant. And how this sometimes comes out in, the nursing station or wherever you work would be like, well, I just don't understand how they can use alcohol while being pregnant. If you ever watch Seinfeld, there's an example there where there's a fortune teller who's smoking while she's pregnant. And Elaine says, I just don't understand with all this information how you can possibly smoke while you're pregnant in this day and age. And that often still comes out within professionals, not understanding. If you have the information about FASD and alcohol during pregnancy, how could you possibly use during pregnancy? And as a person who used during pregnancy, it took me a long time to understand why people felt that way and how people felt that way. And the best way for me to understand is when I don't understand what people do in areas of their lives that I would never do. And so we all have that bias. That is what bias is. That is what judgment is. It comes out in these really sneaky ways without us even knowing it. Like, I can't understand how they could, harm their baby. They're pregnant. They have this opportunity. How can this happen? And it's when we aren't looking at the natural stages of addiction and alcohol use disorder. And we may feel like the baby needs protection from the parent. There's a huge risk with this idea. So if we have staff or if we have resources being developed or if we have leadership who really feels like If someone is using alcohol during pregnancy, our job becomes about protecting the baby from that parent and not treating them as a dyad and not treating them as the parent. We are going to set ourselves up to fracture that relationship with the parent. And if you fracture that relationship, that contributes to harm, further harm to the baby, because we aren't moving in the direction of harm reduction. We aren't able to create that connection. We aren't able to move forward. Can you imagine, you know, if Ron had said to me when I said I couldn't quit using, if he had said, well, when you're ready to quit, please come back and get services. Can you imagine what that would have resulted in? I wouldn't have my kids today and I wouldn't be sitting here with you, is like the actual truth. And it happens every day across Canada when we don't have specialized services. All right, so pre-contemplation is hard, and it's where most of us need to do most of our practice as a professional. Now we see someone moving into contemplation who's pregnant and using alcohol. So they may seem ambivalent or starting to recognize an issue with their alcohol use. They may mention it once in a while. What it might look like for a professional perspective is it might look like they're not taking it as serious as they should. And I'm sure we can all think of conversations we've been like in, like she just doesn't understand if she only did A, B, and C, it would go better, or she's running out of time, like she doesn't get it. She doesn't understand that they're gonna take her baby, is things I've heard professionals say. And the truth is, again, this is a natural, normal stage for someone with alcohol use disorder or substance use disorder to be in, and to take a long time to get out of. It takes a lot of practice to move to the next stage during pregnancy. And of course, pregnancy is the short, 40 weeks is a short time. There's no other population in the world that we expect to change their entire brain, body, and environment in 40 weeks that has such high risks, which of course is taking a baby home, right? There's no other population that we have this expectation of in the world. So it also may look like in contemplation that they don't care enough about their baby. Well, if they can't do this, how are they going to be a good parent? Again, they're marrying the stage of change for substance use or alcohol use to the desire or want to parent, or the stage of change of parenting. We need to separate them out. We need to be able to look at them separately. And what it may look like is continuing to use while saying they want to parent. So I'm going to use Shiwei as an example. Shiwei was so smart with this. Hey, they really, in the early 2000s, right? This is going back to 2003. They were really great at understanding attachment tasks, safety tasks, and what worked for pregnant people who were actively still using and maybe trying to reduce, but not many of us getting to abstinence super fast. So what it would look like for me during my pregnancy is walking into Shiwei where I can access a lunch. Maybe they had a donation of runners, Ron's upstairs, or Sarah Payne's working. And I'm going to go access all of those things, but I'm very, very high. I've been up for 4 days. And then Gio, who used to work at the front desk, and Gio was such a gift to Shiwei, and Shiwei knew she was the most important person because she was the first person you interact with when you enter that program. And she would see me and say, Heather, do you want to get some baby donations today? It did not matter I was high. It did not matter what I was engaging with on the street 2 minutes before. What mattered is I was a pregnant person being treated like a pregnant person because I said I wanted to parent. I had made that decision by this time, even though I was still using. So it can look like someone who is using alcohol, who is drunk, who's under the influence, but they're talking about how they're going to parent or their plans, but they're not in action phase yet. And we need to make that connection in our minds. I've often seen professionals, after we do this type of training, print out the stages of change and have it in their office. Really important before we're engaging with someone. What is the stage of change they're in? Or think about it while they're talking. What is the stage of change they're in? As a professional, it's my job to match my professional goals to my patient or my client's current stage of change. It is not their job to match their actions with my goals for them. That's a very patriarchal approach to supporting people. So what contemplation can feel like? It may feel like decisions and actions need to happen faster. I will hear professionals talking about the anxiety of this needs to go faster, we're running out of time. It can feel like you as the professional are more committed to their desired outcome than the patient. So what that looks like, sometimes people will say like, I'm doing all the work. I'm the one arranging these things, blah, blah, blah. Like, let's say you're getting donations, all of those things, those are actually attachment tasks, and we need to identify that. And we'll talk about that today. But personalizing someone's achievements or relapses or not using alcohol or using alcohol is a really slippery slope for a professional, because you'll run into burnout, plain and simple. It may feel hopeless, sad, you may feel angry or worried about the outcome and feel that somebody should do something. I've literally heard that phrase, somebody needs to do something. And the truth is, you know, again, going back to people do have the right to live at risk. People do have a right to make decision. And this is a very normal stage to be in early in pregnancy. If we can be offering the harm reduction strategies like we talked about, maybe someone is going to use one substance but not use alcohol, and we're going to really center that around FASD prevention. That's fantastic. But we can also improve food, violence exposure, STI exposure, all those things I listed during these stages. We have a big job during these stages, even if the alcohol use is not reducing in the moment. Preparation. So it looks like a person who's pregnant and using alcohol, it looks like they're getting ready to make changes and talking about solutions. So we still may be using alcohol, or we could have reduced our use of alcohol, or we're trying to be abstinent, but we're relapsing on alcohol. It looks like they're open to talking about plans. Maybe they're getting a tiny bit excited. It looks like maybe I'm talking about going to detox, but I'm not phoning detox quite yet. So I'm there, but I'm not there. I may commit to a time or a place for action. Preparation for a professional, this feels better. So this feels better than pre-contemplation or contemplation for most perinatal professionals, because it feels like we're getting closer to a goal of healthy outcomes for parents and babies, which we all, of course, want to support. It may feel like a relief that the patient is finally moving along the continuum of change. It can feel like there's some hope, there's light at the end of the tunnel, and it can also start to feel hopeless if you're working with people in pre-contemplation and contemplation most of the time. So if we've only moved to preparation, let's say 1 week before labor and delivery, and you only have someone who starts talking about abstinence 5 days before, that can feel hard. But at the same time, if you get used to the idea that most people won't even reach this stage before they deliver a baby, we're doing really, really fantastic, is the truth. And then action stage, like I said, this is the most comfortable for people, for perinatal professionals and helping peers, working with pregnant people using alcohol. We feel happy for them. We're excited, relieved, hopeful. There's less urgency. They're doing what they're supposed to do. You can finally relate to them because you maybe feel like you would never use alcohol, and now it all makes sense because they're abstaining, or they're going to detox, or they're going to treatment. These things feel wonderful. Often, again, this isn't coming until the birth of a baby. That is the absolute truth we need to get comfortable with. What it looks like is going to detox or a stabilization, getting on a wait list, going to a bed-based program. You know, here in BC, we have 7 beautiful bed-based programs, from Caris to Ellendale to Tupas Lodge to Sacred Cradle. Now on the island, we have some really great options. That feels really good to support a pregnant person going into one of these options. Also, they could be just attending peer support meetings for the first time, or a day program. Whatever that looks like, they're taking action towards abstinence or harm reduction, and it feels good as a professional. This is easy. I would never need to teach anyone how to support this. We were all taught in whatever schooling, education, or training you've took. how to support someone to move along the continuum. What we weren't taught is how to support someone who's not moving along the continuum of services and programs. And that is where we're going to be most effective in our work with pregnant people who are using alcohol. Maintenance. This one is tricky. I'm just going to look at the chat. No, I'm going to look at the chat in a second. That's too long to read for me in the moment. Okay, so maintenance. What is tricky about maintenance is people think there's a start and an end, or it's much shorter than it actually is. So it's normal to go into maintenance stage, and of course, we all know this, and then part back to pre-contemplation, contemplation. We can bounce back and forth between the stages, but also maintenance is very hard and a lot of work. Maintenance, let's say we have someone who's abstaining from alcohol, they're early in their pregnancy, that feels good, they've taken action, they're in a bed-based program, maybe they got stabilized at FER, they went to detox, whatever that looks like. When someone's in maintenance stage, professionals relax a bit. Maybe some of the supports even pull back a bit. This is not the time to relax or pull back. This is the time to lean in. So maintenance and long-term abstinence or long-term harm reduction is really, really difficult, right? Similar, again, I use obesity just because I read quite a bit about it. Long-term weight loss or maintenance in obesity or opioid use disorder when using methadone or Suboxone, or long-term maintenance in alcohol use disorder is the trickiest part. And this is also, of course, where we're learning to deal with life's difficulties in a way without the use of alcohol. And in this case, we're also going to learn to be a parent if that's something what we want to do. That's a huge undertaking. That's huge. Requires major intervention, specialized skills, great ideas, hands-on support. It is much larger than what general population of professionals believe it to be. And we need to recognize that. So what it looks like is maybe our pregnant person is now abstaining from alcohol, they're accessing self-help groups or counseling, they're engaging in wellness and healing activities that have proven helpful for themselves. And that, of course, can, again, look like dancing, beading, artwork, drumming is a great one. Lots of different cultures, including people who identify as Indigenous, have lots of different healing practices. It looks like having a relapse prevention plan. It looks like being able to identify when a relapse occurs and managing it and being able to move on from relapses with strength and knowledge. So maintenance does not mean that relapse isn't going to happen. Maintenance means that we're able to get back on track, which is a beautiful, beautiful way to be. So the take-home message about goals and stages of changes that is often left out in our training around stages of changes, if you've ever been to gone over this elsewhere, is we miss the piece where as a professional, I need to match my professional goals to my participant's stage of change. It is not the other way around. It is not their responsibility to match their actions to what I want for them or my professional goals for them. That can be really hard for people. The opposite, or like the beautiful gift of that being really hard, is it's also a relief for a lot of professionals. If someone is not in action stage, stop trying to make them be in action stage. That looks like a lot of work that is only driving you apart. And what I love about this photo that I use on this slide is all the people are connected. I consider the professionals the red people. If you are matching your professional goals to your patient's stage of change, you become that connected center. You're improving your relationship long-term. You're working towards improving outcomes for someone, preventing FASD in the babies that are being born. If we're not matching, these are all our clients on the outskirts who are not connected, who are not moving through the continuum, and who we've really left behind, which is super unfair, right? Christy, are there questions there?
No questions, just comments.
Okay, cool.
Yeah, I have two comments. One from one side, I've heard heavy cannabis users tell me their doctor said they don't need to quit, just slow down while pregnant. And The other comment says, it does feel very hopeless when that pregnant person has FASD and there is no move towards preparation. Living on the streets and safety is not their reality. So heartbreaking. Yeah.
Fair. Both of those comments are really great. For sure. And careful, like, what do we have to do? What do we not have to do as pregnant people? We don't actually have to do anything. I feel like the language in that first comment, and it's absolutely the language that would have been used, but the language of like, you don't have to, or you can, is a very directive language. When I am teaching, I talk about the importance of sharing the evidence-based information, talking about the pros and cons, and exploring it with a patient, which is very different than a patient asking for advice and someone telling them what to do. And what that can create sometimes, which is what I think, if I'm reading between the lines in that first comment is being said, is almost like what did someone say they could do this? If in an ideal world, maybe they could try abstinence, if I'm reading between the lines properly. So it's really, really nice to relax as a professional, offer evidence-based pros and cons, risks, benefits, talk about benefits. Benefits of alcohol use, benefits of substance use. There are benefits, otherwise we wouldn't be doing it. So let's dig into what the benefits are, because that can also give you an opportunity to be like, a really easy example is someone who says, I use cannabis or fentanyl at night to sleep because I wake up to nightmares. That's a really common use of our sedative or relaxing type drugs for people who have experienced trauma, and they don't even know they've experienced trauma. They aren't identifying that. What that conversation, because I elicited that information of what is the benefit of you using this substance, what that offers me as a professional is an opportunity to start thinking about what are other ways we can prevent those nightmares, get back to sleep. What are some things? Maybe I can go back to my office and research it. So if we aren't eliciting the benefits from the population we're working with, we aren't able to actually find solutions for the future. I love that. And then I just think on that second comment, language is so important about not giving directives, because that isn't supporting an individual to become the best version of themselves. Some pregnant people, this one was about cannabis, so some pregnant people, the best version of themselves is to just use less and not quit. But other pregnant people, the best version of themselves is to be abstinent. And there's so much push around harm reduction, which, as you know and can tell, I absolutely believe in harm reduction. My only caution around directing harm reduction is that some people like myself cannot use any substances and safely parent. So if someone had pushed me towards harm reduction instead of explored with me what does my individual substance use look like, I may not have my kids today. There are many people who advocate for you can still safely parent and use some substances if you can do so safely. That is one population. I'm part of a population who needs to be abstinent still at this day, to this day. So 17 years abstinent, right? Going into 18. I know if I drink alcohol, I would go get cocaine. I can feel it in my stomach. I travel, I like to go to Vegas, I like to go to Mexico, blah, blah, blah. I would be a nightmare in all of those places from one drink. I am so lucky I had a professional later in my life who was a counselor who was able to explore with me to find out my own ideals around my substance use. For me, it is abstinence, and that's what allows me to parent safely. So I did like that second comment around really cautioning. Prescribing harm reduction for everyone is the solution. That isn't the point of what we're talking about today at all. We are talking about when a pregnant person is using alcohol and says, I cannot stop today. We have a whole bunch of other things we can do, and then we're going to ask again tomorrow, and we're going to support them down that continuum of service instead of seeing them drop off. I hope that makes sense. Great comments. Thank you. When we talk about stages of change, how do I know if I'm doing it right? When I do training for acute care nurses, so maternity and labor and delivery, and I've done that all across BC, people will say like, but if I don't fill out the intake form, or if I don't fill out the program, or if I don't do everything I'm supposed to do, it doesn't feel like I'm doing my job. Or there's even fear of I'll get in trouble, and that's fair. That being said, the indicator of knowing, how do we know if we're doing it right? If we are matching our professional goals to the patient, participant, or client stage of change, is if we leave that little interaction feeling positive about it. It's very simple. So if you leave think about a patient, client, or participant you've had in the past who was actively using. I think everyone's had this experience. And think about one interaction you had with them that felt really awesome when you left that interaction. If you are feeling really awesome, I'm going to assure you in 99% of the occurrences or incidences, your patient, client, or participant also is leaving feeling awesome. That is setting us up to work together and work through the continuum of service and stages of change. If you leave an interaction and you're upset, angry, mad, pissed off, any of those words, sad, I guarantee you that your patient, client, or participant also feels that way. So when people say, when professionals start implementing this idea, what starts happening? I've had phone calls from people who said, Heather, I was working with this family, super marginalized. They were unhoused. They were pregnant. They were using. They came in. They got assessed. We were going to discharge them. And I let them take all of the sandwiches out of the fridge. And that felt awesome. And it was so cool to see someone who's like, I know I created relationship. They felt trust here. They felt supported here, improved their food security for today or their nutritional intake for today. And I made them feel welcome in this space for people who are literally starving. Let's feed them, first of all. And that professional, they were like, when you taught me that changed the way I viewed what I was going to do with the patients who were coming in. I had another nurse who's used to be she's greatly inspiring, super, super smart, much more experienced than me in maternal child health, labor and delivery, right? I'm a pretty new nurse in general, especially when I worked on labor and delivery and maternity. I would have the lowest amount of experience sometimes on the group of 5 people around LDR. That being said, around PSU, I tend to be the most experienced in the room. So really exciting. The super, super experienced nurse had called me at home one day and she was like, Heather, I got to support this patient. There was a contraindication to breastfeeding, but I got to support them to do skin to skin with a sports bra on. I took that patient out for a cigarette after she birthed. And then I made sure that patient, we washed up, blah, blah, blah. I made sure that patient did the first feed with formula. She had never formula fed or fed any of her previous babies. And then when this patient was going to leave without her baby by choice that day, she said, instead of taking the baby, I pushed her and the baby down to the NICU in a wheelchair, and she got to place the baby in the bassinet. And she was so thrilled with how that worked out because she knew this was the goal. How is that patient leaving you? That childbearing patient or client or participant, how are they leaving your interaction? She knew that this was her goal for the moment because she knew that mom was leaving. She knew she was going to choose to leave, and how could she reduce the trauma and improve the experience for both that baby and that mom? Now let's think about the baby in that situation. That baby had a right to have skin to skin. That baby had a right to have its mom safely feed a bottle with formula. That baby had a right to have a calm mom who had had a cigarette after a birth. If you've ever been a cigarette smoker, you know that after you push out a baby, you need a cigarette. We need to be supporting people to use their coping skills so that they can maintain their emotional status during times of crisis, right? We do need to support the coping skills. So really, really beautiful when we start focusing on how am I leaving this interaction? How am I leaving this person leaving me? And it often has to do with meeting them where they are at. And the actual definition of meeting them where they're at is to match our professional goals to their stage of change. Beautiful way to work. I just want to choose what I'm doing for 2 seconds. All right, so tools to talk. We have 10 minutes left. Christy, you interrupt me if there's any questions. Otherwise, I'm going to go right to the end, okay? Thank you. So tools to talk. How do we start conversations? Really great practicing is to start with person first language and gender inclusive language in the context of today. So you'll notice I do my best to speak in person first language and write in gender inclusive language as well. So negative connotations versus neutral connotations. When we are talking to people or about people, people are hearing us. If we're talking in our program rooms, in the office, in the nursing station, in the med room, I don't care where you are, people are always hearing the language we're using and we're role modeling that. So we can look at a negative connotation list versus a neutral when we're using person first and gender inclusive. When we talk about person first language, we're putting the person before the diagnosis, issue, or situation. So an example would be a person diagnosed or a child diagnosed with FASD instead of an FASD child, right? An example would be negative connotation would be alcoholic pregnant person or alcoholic pregnant woman. The neutral connotation is a pregnant person who uses alcohol or substances. An addicted baby is not a thing that exists. So really negative connotation when we talk about people's babies that way. The neutral connotation is a baby exposed to alcohol. Addiction, the word addiction in itself really means repeating the same thing regardless of consequences. So babies are not addicted. Babies are actually, they've been exposed prenatally and they're experiencing withdrawal symptoms. They're not repeating something over with free will, regardless of circumstances. And then last one I'll do is just negative connotation would be sober parent. So we really want to talk about a parent who is sober or abstinent. So putting that diagnosis or situation second. It takes a lot of time to repeat your language to be gender inclusive or to be person first, and mistakes are going to happen, right? I have this really great friend, his name is Jesse, and he's spoken for us at BCA Pop before. He is a person who identifies as two-spirit and gay. And he does a lot of work in the perinatal world, which is super exciting. I love listening to him. And he was the one who had taught me that idea of if you make a mistake, especially around gender inclusive language. So let's say I call someone the incorrect pronoun, even though I've been informed of their correct pronoun terms. It's really important when we make a mistake to own the mistake, correct it, move on. Instead of making ourselves the victim and going overboard with the apologizing and then having to make the patient make us feel better, right? Really, really important learning. So mistakes are going to happen. We correct it, we apologize, we move on, and we don't make ourselves a victim as the professional. I love to talk about relapse prevention plans. So we're going to talk about that now, especially when it comes to alcohol use and pregnancy. We know the more that a pregnant person can reduce or ideally abstain from alcohol, the less risk there will be during that pregnancy for that baby to eventually grow into a child who is diagnosed with FASD. So many people, we throw out the term relapse prevention plan all the time, but not many professionals know, how do I support someone to do a relapse prevention plan? When we talked about the cycle of addiction or alcohol use disorder and the cycle of recovery, we need to be thinking about that when we're supporting someone to do this. We have these super cool cards You can make your own, you can print some online. I don't care what you do. We also sell them, but you can make your own version. It does not bother me. So we want to ensure that we have something physical when we're supporting a pregnant person who's using alcohol to create a relapse prevention plan. We need them to at least be in contemplation or action stage in order to move forward on something like a relapse prevention plan. Talking to someone who has told you they're not ready to reduce their alcohol use about a relapse prevention plan, again, can create a wedge and can create harm. Do not move to action stage when your participant is not in contemplation or action stage yet. So, when we think about a relapse prevention plan, what does that actually mean? It means that someone has, if they are thinking about using alcohol, physical dependence is a huge thing. But it also means that the mind has these pathways of well-worn highways towards I have an issue, whether it's I stubbed my toe or I experienced a child apprehension, anywhere in there, and I use alcohol, and that's how I cope. That is a well-worn 8-lane highway in my brain. My brain is plastic. I've practiced that for years. I've created a highway in my brain. It's been an actual like neuroplasticity change in my brain that is a very, very quick reaction, and it meets my needs as a person with alcohol use disorder. When I'm trying to do relapse prevention plan, what I have to do is physically interrupt that very, very quick electrical current that goes through my brain that goes from this sucks to I'm going to use alcohol, that's the solution. I need to physically interrupt that. So oftentimes when we talk to people about their cravings to use alcohol, we'll ask them something like this first question, which is on the back of my physical card. What can I do if I think about using? And that's how we're going to do a really quick relapse prevention plan with someone. So what can I do? And do is capitalized, because if I am the person who's thinking about using alcohol, something's happened, brain connection is set up, it's a very quick highway, there's very little time to think it through. I need to physically do something to interrupt it. The list you will get back from people sometimes is, I'm going to have a bubble bath. I'll listen to classical music. I'm going to have a nap. I'm going to relax. I'm going to light a candle. I'm going to do aromatherapy. Those techniques are not relapse prevention techniques. Those techniques are relaxation techniques. Those are the things you do at the end of a long workday. Those are not techniques that are going to interrupt this very concrete highway in my brain when I'm thinking about using. Things that will interrupt my brain: going for a run, walking, going to the gym, drumming, sewing, beading. What do lots of people are really into physical activity in early recovery, right? All the men and women are just jacked and chiseled for the first year of recovery, and then we all get a little fat and sassy as time goes on. But in the initial part, we need to be doing these physical things. The best recommendation I ever got, and this was because I had 2 babies at home and was struggling with my cravings 24/7 for 6 months, no word of a lie. The best recommendation I got as a parent, because we need to think about if someone moves into parenting, how do we support that relapse prevention plan, is reading recovery literature out loud. Anything about wellness, anything about self-care out loud. My brain cannot physically think about using alcohol while I'm reading something out loud and paying attention to it. So we can do that anywhere. I used to suggest that to my pregnant people as well as my people who were not pregnant in detox all the time. It's a great technique to get into using because you can use it anywhere, and you can have a child safely cared for in your home while you interrupt that circuit. And then who do I call if I think about using a relapse? As a professional, I want to know you have people that you deem safe to call, that you feel comfortable to call when you're thinking about using in order to prevent a relapse, okay? So really important to think about how we can do these really simple steps for people who are using alcohol during pregnancy. The last couple of minutes, I'm just going to spend on some evidence-based resources for patients and for professionals. So the first one, this is more of a prevention tool. So this would be something I would use for someone who is not pregnant yet, right? Remember when we talked about prevention strategies? Great booklet by the Center of Excellence for Women's Health. I'm going to send you the links to all of these for people who are not yet pregnant so that we can be preventing FASD earlier in the lifespan before pregnancy, which of course is ideal. Christy, your website is here and the site specifically to alcohol and pregnancy. So I'll send the link with that, which had some beautiful resources. And then Understanding FASD, a resource for service providers. This one again is from the Saskatchewan Prevention Institute. Really beautiful, along with some postcards that are speaking to their, what is that word? Campaign around becoming the village, but also engaging with partners and how much influence that can have in pregnant people not drinking during their pregnancy. Super, super cool postcards. I will also send you the BCA POP PSU website. So of course we include alcohol specifically and FASD prevention on our list of resources, and this is reviewed every quarter. As far as learning how to work in a trauma-informed way, I'll send you the tip guide. It was done in 2013. It's getting old. It's still completely applicable. I love this resource. And then Doorways to Conversations is another great one. I love it because it has tear-out sheets for different professions on how to start conversations with people who are using alcohol or substances. Then a really great FASD prevention blog is through CAN FASD, which I'm sure many of you are aware of, and I will send you that one as well. On my last slide, I just have contact information for you if you want to subscribe to BCA POP, so my organization's e-newsletter. That what are those things called? That QR code is there for you. You can connect with us any of the other ways, and I'm just so thrilled to have spent this time here with you today talking about how we can prevent FASD in the pregnant populations we are working with when someone is struggling with alcohol use disorder, and how we can provide that best practice care that really improves outcomes, not only for the infant being born, but also for the parent or the mother of childbearing age who may go on to have other pregnancies as well. Really important work. I super appreciate you spending the time with me, and I hope to do this again sometime. Thank you so much, Christy. You're on mute, Christy. One of us has to do it every time, right?
Yeah. Thank you for this presentation and sharing your knowledge with us today. And thank you all for joining this webinar. When you close this window, you'll be directed to a link where you can complete a short survey evaluation of this session. Completing these evaluations help us to create programming and resources that support you in your work, and we appreciate the time it takes to complete them. Have a good day.